Hi guys, good evening, good evening. Can you all see me? Can you all hear me? Alright guys, so let's get started. So the last episode that we had, we spoke about the various surgeries in the peptic ulcer disease, right? So we're talking about the complications which are associated with the peptic ulcer disease. So we're talking about the complications associated with peptic ulcer disease. So we talk about complications associated with peptic ulcer disease, right? Hi guys, good evening. Yeah, all right, so let's get started. So let's see the complications associated with peptic ulcer disease. There are two standard complications that you have. Number one, it is going to be bleeding, and number two, it is going to be perforation. It is going to be perforation. Now, whenever the bleeding from the peptic ulcer disease will occur, the bleeding can take place in both gastric ulcer. It can be in both gastric ulcer as well as duodenal ulcer, as well as the duodenal ulcers, right? When the bleeding occurs in the gastric ulcer, it is because of erosion into the mucosal surface. It can erode the splenic artery, it can erode the pancreas. Anything is possible when it is going to be the gastric artery. When it comes down to the duodenal ulcers per se, now you need to understand that duodenal ulcers, it is the posterior ulcers that usually bleed. So in the duodenal ulcers, the bleeding occurs more commonly in posterior ulcers. It occurs more commonly in a posteriorly situated ulcer, and the most common source of bleeding is going to be the gastroduodenal artery. The most common source of bleeding is going to be the gastroduodenal artery. Now, let's say if a patient is presented to you with a bleeding peptic ulcer disease, what will be its clinical manifestation? So, when a patient of a bleeding peptic ulcer disease presents, how will he present to you clinically? So, the bleeding in a peptic ulcer disease, when you talk about clinical presentation, he will present to you with signs and symptoms of upper GI bleed. So, we categorize the bleeding into upper and lower GI bleed. No, any bleed that occurs above the level of ligament of teats or the hepatoduodenal ligament is what we call as an upper GI bleed, and below that will be called as a lower GI bleed. Now, what are the signs and symptoms of a upper GI bleed? Now, because the patient is going to have bleed, if I just comprehend it this way, let's say this happens to be the esophagus, this happens to be the stomach, and this happens to be the duodenum. Either of the sides of the bleed, either side of the bleed, either it is going to be the gastric ulcer or it is going to be the duodenal ulcers. Whenever it is going to bleed, whenever it is going to bleed, the blood is going to go up in the form of vomitus, and certain amount of blood will go down as well, right? So what are the impact that it is going to create, right? The patient will present to you with hematemesis. The patient will present to you with hematemesis. Along with hematemesis, the blood that goes down will cause melena. I hope everybody knows melena is your black tarry stools. And remember the minimum amount of blood required to cause melena. That's also important. Remember the minimum amount of blood required to cause melena. The minimum amount of blood required to cause melena is 60 ml. The minimum blood requirement to cause melena, absolutely correct, Raj. It is going to be 60 ml. Now the patient has hematemesis, he has melena. Along with that, what else? Obviously, there's because of blood loss, it will also be associated with anemia, and then anemia is because of the blood loss that you have. So you have a patient who has presented to you with an upper GI bleed, who has hematemesis, melena, as well as anemia. With, if there's an extensive loss, there'll be signs and symptoms of shock as well because of volume loss, right? Now, how would you evaluate this patient in terms of the protocol? Now, in the management, the first one is to secure two large IV cannula. Start the patient on IV fluids. Start the patient on IV fluids basically to resuscitate, right? Now you see if the bleeding is still persistent or not. If the bleeding is persistent, you can give tranexamic acid, which is an acceptable practice. But more importantly, I need to evaluate. So I will do an upper GI endoscopy. Now, based upon the upper GI endoscopy, we have a classification for an upper GI bleed. Can anybody tell me what is the classification that we follow? Classification that we follow for an upper GI bleed. Quick component. What is the classification? Quick feedback. So based upon the upper GI bleed, what is the classification that you have? We have the Forest classification. We have the Forest classification. Absolutely correct. This is to evaluate the upper GI bleed that is going to be present. So when you put an endoscope, you will look at the base of the ulcer, and based upon that, you can predict whether it is going to be a high risk for recurrence or a low risk for recurrence, right? According to the Forest classification, when you see the base of the ulcer, now imagine this is the base of the ulcer, and if you see there is a visible blood vessel at the base of the ulcer, and from this visible blood vessel, if there is an active spurt of blood, now this is what we call it as the Forest classification 1A. So this is what we call it as 1A. So there is active spurting of blood. There is active spurting of blood with visible blood vessel. At the base of the ulcer. At the base of the ulcer will be noticed, right? So one, it is going to cause an active spurt. Second, you will be seeing a visible blood vessel. The next one that you have, you can see the base of the ulcer is there. There is a visible blood vessel that is present at the base of the ulcer. But this time you see the blood is only going to ooze. There is no active spurt, but there is a slow drip by drip ooze that is present, right? So here we say there is ooze of blood that is present. So in a 1B, there is an active oozing of blood. There is an active oozing of blood, and this also consists of a visible blood vessel. A visible blood vessel at the base of the ulcer. At the base of the ulcer, that is 1B variety. That is your 1B variety, right? Next you have, I'll just reassign it here. The next that you have is a 2A variety. Now in a 2A variety, you will see that there is the base of the ulcer. Logically, you should see there is a visible blood vessel, but there is no bleeding. And this is what we call it as a 2A ulcer. It is a non-bleeding visible blood vessel. A non-bleeding visible blood vessel is what we call it as a 2A variety. Now in a 2B variety, there is no blood vessel, but I can see there is presence of an adherent clot. In 2B variety, there is presence of an adherent clot. This is adherent clot. Then you can see there is ulcer that is present. There is a black spot on the ulcer. So you'll see there is a spot on the ulcer that is present. You will see there's a flat spot at the base of the ulcer. This is 2C. So 2C is what we call it as a flat spot in ulcer cater. It is the flat spot in ulcer. It is present a flat spot in ulcer. And the last one, you can see only the ulcer, nothing else. The clean based ulcer. It is the type 3 variety, or I can say the class 3 variety, where you have a clean base ulcer. Where you have a clean base ulcer. So based upon on upper GI findings, these are the various components that you have. 1A, there is an active spurting blood vessel, visible blood vessel. 1B, there is ooze. 2A, only visible blood vessel. 2B, there is an adherent clot. There's a flat spot on 2C, and then the clean base ulcer, which is present on this context. Okay? Now, when we say the characteristic of the entire categorization that you have, we are going to assess the risk for rebleeding, right? So when you talk about the risk for rebleeding, we say we can categorize the risk for rebleeding into various categories: high, intermediate, and low. Remember the first three that you have, that is 1A, 1B, and 2A, they're considered to be high risk for rebleeding. These are considered for high risk for rebleeding. Whereas this is considered to be as the intermediate risk. 2B is considered to be as intermediate risk. It is considered to be as an intermediate risk, and 2C and 3 is considered to be as low risk. They are considered to be as low risk for rebleeding. They are considered to be as low risk for rebleeding. Why do you have to read so many classifications in surgery? Beta, imagine there is an ulcer which is bleeding. How will you manage? Now, if you have a patient who is presented to you with 1A variety and you have a patient who is presented with type 3 variety, can you treat both of them same ways? The answer is no. So after doing so much amount of research, study, analysis, patient assessment, we found that broadly we can classify any patient into these categories, and then based upon that you will be able to give a tailored response or a management, right? So to create a very specific targeted management, you need to know classifications. You need to understand that when a patient comes to you, based upon the upper GI endoscopy, you know how are you going to evaluate, what is the further course of management. Everything can be determined by this particular component. But a spot is a fibrous, or I can say vitous tissue. It's a healed ulcer. When there's a spot, we call it as it's a healed ulcer. Or I can say a healed ulcer spot. A healing spot that is present, we call it as a flat spot. Clear? So this is on the basis of your upper GI endoscopy. Now, how would you like to manage? Right? So management of a bleeding peptic ulcer disease. Of a bleeding peptic ulcer disease. Now, when you talk about the management of a bleeding peptic ulcer disease, you will see whether there is presence of active bleeding or not. We'll see the status of active bleeding which is present, or if the active bleeding is absent. If the active bleeding is present, the current protocol says the first line is to put an endoscopic vascular clips can be applied. If this does not work out, then you can go ahead with surgical ligation of the blood vessel. It is the surgical ligation of the blood vessel. So one, you can go ahead with the endoscopic vascular clips. If not surgical ligation, if there is no active bleed, then you have to treat peptic ulcer disease. So as we all understand, eradication of H. pylori, acid diversion, all these are the targets that you're going to taken across. Clear? Clear? So this is how you're going to manage your peptic ulcer disease. Clear, guys? So that's bleeding in peptic ulcer disease. Now, this is very important if you're preparing for competitive exams. Forest classification is one of their famous favorite exam questions. Okay. Now, going to the next one. The next complication is going to be perforation. The second complication that you're going to encounter is going to be perforation. And this perforation is also called as the hollow viscous perforation. Now, if there is a hollow viscous perforation, how would a patient present to you? Right? Now, when there is a hollow viscous perforation, usually it is the duodenal ulcers that perforate. So, in terms of perforation, remember, see, gastric ulcers can also perforate, duodenal ulcers can also perforate. But more often than not, when you talk about the duodenal ulcers, in duodenal ulcers, it is usually the anterior ulcers that perforate. It is the anterior ulcers that usually perforate, right? Now, if they perforate, what is going to happen? Now, if you take this as a representation of the esophagus, this happens to be the stomach. And let's say this is where we're talking about the duodenum. And I'm saying this is where the perforation is going to occur in the first part of the duodenum. Now, when the perforation is going to happen, what are the content that is going to come out? One, the food particles that are going to be present inside the stomach and the duodenum, they are going to spill out, right? Apart from that, some amount of blood is going to spill out. Some amount of serous secretions are going to spill out. But more importantly, one of the most irritating one which is going to spill is going to be the bile, right? So the bile is going to spill out. The blood is going to spill out. You have the bile, you have the blood, you have the food particles, and then you have the GI secretions. Now, all these content, when they're going to spill out, they are going to fall into the abdominal wall, right? Now, if you look at the abdominal wall, this is the abdominal wall that is present, right? Now, this abdominal wall is going to lined by the peritoneum. So, this is the peritoneum that is present, right? Now, all the content that is going to fall is now going to irritate the peritoneum. Remember, among all the given, the most irritant for peritoneum is going to be bile. Now, the bile is going to cause severe irritation of the peritoneal space. Now, as the bile causes severe irritation of the peritoneal space, it will now result into perforation peritonitis. This will now present to you as peritonitis. Now, when you have a patient who is presented with peritonitis, what are the clinical presentations, right? So, we talk about the clinical features of peritonitis. Itis is inflammation of ruber, callar, dollar tumor. So, all of them will be present here also, right? So, patient will have sudden severe onset. There will be sudden severe onset of diffuse abdominal pain. There will be diffuse. There will be diffuse abdominal pain. Sudden severe onset of diffuse abdominal pain is noticed, right? Along with that, as there is more amount of peritoneal fluid is going to accumulate, it will also associate with abdominal distension. Remember, every other intra-abdominal inflammation will cause paralytic ileus. Now, because of paralytic ileus, it will be associated with nausea and vomiting. It will be associated with nausea and vomiting. So, there's sudden severe onset of diffuse abdominal pain. It will be associated with abdominal distension with nausea, vomiting. Along with that, the peritonitis will also trigger fever. It will result in fever. Because of paralytic ileus, it will have non-passage of stools and flatus. Patient is going to have non-passage of stools and flatus, right? So sudden severe onset of abdominal pain, which is going to be diffuse in nature with abdominal distension, there's nausea, vomiting, fever, and non-passage stools and flatus is there. Now, as soon as this patient lands up onto the casualty, I would like to examine. Now, on this examination, there are signs which elucidate the patient is in shock. How do you know it is shock? The heart rate is more, that is tachycardia, and the blood pressure is low. There is hypotension is present, right? Apart from that, when you evaluate, there is diffuse tenderness in the abdomen. There is diffuse abdominal tenderness. There is diffuse abdominal tenderness. That means the entire abdomen, wherever you touch, he won't let you touch it. There is diffuse abdominal tenderness. Now, he won't let you touch, so there will be presence of guarding. Guarding is like when you try to touch the abdomen, he will prevent. He will not let you touch it. There's going to be guarding. And with great difficulty, when you try to touch it, because the peritoneum is continuous with the abdominal wall muscle, the entire abdominal wall goes into spasm. Hence, there is abdominal wall rigidity is present. There is presence of abdominal wall rigidity, right? So there is signs in terms of shock, diffuse abdominal tenderness, there is guarding, there is rigidity that is going to be present, right? Along with that, see, there is rebound tenderness and surrounded by generalized tenderness area is present. So the site where you have perforation, that area will have rebound tenderness. An area of rebound tenderness surrounded by generalized tenderness. Surrounded by generalized tenderness. An area of rebound tenderness surrounded with generalized tenderness is noticed, and this is what we call it as the Bloomberg sign. This is what we call it as the Bloomberg sign. This is what we call it as the Bloomberg sign. परफोरेशन में विजुअल पेरिटोनियम भी परफोरेट होता है, एकदम परफोरेट होता है बेटा. अगर विजुअल पेरिटोनियम परफोरेट नहीं होगा, विजुअल पेरिटोनियम क्या है? सिरोजा. सिरोजा का ही दूसरा नाम विजुअल पेरिटोनियम है. अगर विजुअल पेरिटोनियम परफोरेट नहीं हुआ तो ये सारा कंटेंट आपके पैराइटल पेरिटोनियम में कैसे स्पिल करेगा? ठीक है ना. वंस यू हैव दिस पेशेंट, आई वुड लाइक टू इवैल्यूएट. तो हमारा जो फर्स्ट इन्वेस्टिगेशन है इन टर्म्स ऑफ इवैल्यूएशन, diffuse abdominal pain, nausea, vomiting, non-passage stools and flatus, guarding rigidity, all this is present. You can think either obstruction or perforation. So the first one is going to be an erect X-ray abdomen. So when you do an erect X-ray abdomen, what is the finding that you will see? Any idea? What is the finding that you will see? Quick feedback. Quick feedback. I'm just showing you the X-ray image. एक second. बेटा गैस अंडर डायफ्राम, बट लेकिन कौन से साइड पे? So this is how the X-ray image would actually look like. Okay. So when you do an erect X-ray abdomen, this is how it is going to look like. Okay. Now what are the findings that you have, right? You can see presence of free gas under right hemidiaphragm, right? You can see that this happens to be the right side, this happens to be the left side. Now you can see this is the diaphragm that is present, and this is the free gas which is present. This is the free gas under right hemidiaphragm. It is free gas under right hemidiaphragm. See, the free gas is there on this side also. You can see the free gas is here, which is present here. But the more amount of free gas, see, if there is a free gas on either side, it should be considered for perforation. But if the free gas is more, if it is present right side, then it has to be hollow viscous perforation, right? So free gas under right hemidiaphragm is what we call it as the sign for hollow viscous perforation. Can you tell me any other sign? Any other sign for hollow viscous perforation? Any other sign? Have you heard about regular sign? Have you heard about regular sign? I'll just show the X-ray image for that. There is something called as the regular sign. Then there is something called as the dome sign or the football sign. I'll just show you both of them. X-ray. Okay. Now another sign that you will see here is going to be the regular sign and the dome sign. Now what is this regular sign or the dome sign that you can see here? Normally, no, if you take this as the representation of the bowel wall, the air is usually present inside this, right? So you can see air in X-ray. So this part is actually visualized. Okay? So I'll be able to visualize this part. But if the air leaks out and the air is present on the outer side also, so there is air on one side and there is air on other side, and obviously there is one membrane like presentation, or there's something which is dividing these two, and that is a bowel wall. Normally in X-ray the bowel wall will not be visualized, but if you see carefully here, you can see very carefully the bowel wall is clearly visualized, right? If the bowel wall becomes demarcated, this is what we call it as the regular sign. This is what we call it as the regular sign. This is what we call it as the regular sign. On the other hand, if the entire abdomen is going to be filled up, if the entire abdomen is filled up with the gas, it is going to push the diaphragm on both the sides, and the entire abdomen feels as a distended space. Even the pelvis is pushed downwards. The entire abdomen is pushed, and this is what we call it as dome sign, or also called as the football sign. So there is a regular sign, there is dome sign, there is football sign, and there is free gas under right hemidiaphragm, right? Clear? Okay. So this is on the base of erect X-ray abdomen. Now, in fact, if I say what is the investigation of choice, it is going to be an erect X-ray. But if I say what is the best investigation for hollow viscous perforation, it is going to be CCT abdomen. Now, what is the management protocol? So when you look at the management protocol for the hollow viscous perforation, it is to stabilize the patient first is the most important aspect that you need to do. The first one is to secure two large IV cannula and start the patient on IV fluids. Start the patient on IV fluids, right? Now, once you have done this, put a nasogastric tube. Put a nasogastric tube, that is for decompression of the stomach. Put a nasogastric tube. Now, this nasogastric tube is also what we call it as the Ryle's tube. So, insert the Ryle's tube. Now, when you're going to put the Ryle's tube, the purpose of putting the Ryle's tube, it is to decompress the stomach. It is to decompress the stomach. It is to decompress. It is to decompress the stomach. Right? So you put a nasogastric tube in order to decompress the stomach. That is the first thing that you do. So secure two large IV cannula, start the patient on IV fluids, and then put the nasogastric tube in order to decompress the stomach. Now, once you put the nasogastric tube, you have to put Foley's catheter. Now, Foley's catheter is basically to measure the urine output to assess the status of shock. It is to measure urine output in order to assess status of shock. In order to assess the status of shock. ठीक है बेटा दो कैमरे लगाने दोनों साइड पे ना ताकि whenever you require एक से फ्लूइड दे सकते हो दूसरा सैंपल ले सकते हो ना. For that you have to put two large cannulas, right? Now once you have catheterized the patient, you have decompressed it, started the patient on fluid. Now take the patient for exploratory laparotomy. Take the patient on exploratory laparotomy. Now this exploratory laparotomy, you can do a laparoscopic exploration or you can do an open exploration. Both are accepted. Now currently if you see, laparoscopic is preferred over open. Laparoscopic is preferred over open. So what you do in exploratory laparotomy is you will identify the site of perforation and then you do something called as the Graham's omental patching. You do a Graham's omental patching. This is standard for your perforation peptic ulcer disease, right? Now what is this Graham's omental patching is? Now you take this as the representation of the esophagus. This happens to be the stomach and let's say this is the duodenum. Now imagine if this is the site of perforation that is present, right? You identify the site of perforation. The first thing I'm going to do is going to do a primary closure. I'm going to suture this part. Now, if I suture this, it is not going to be enough because obviously it can give away again. So what do you have? On the greater curvature of the stomach, you have this policeman of the abdomen, which is called as the omentum, which is lying across it. So this is where the omentum is present. So this is the omentum which is present through and through. So you have the omentum which is present here. Right. So what you do is you take a little bit of omentum. You take this little bit of omentum and then you migrate the omentum to this point and then you seal this off, right? So when the omental migration is going to occur, you will take this part of the omentum and then you will put it on top of here, right? It is like an omental patch that you're going to put, like, you know, when you do a puncture repair, you put a patch on top of it. This is that puncture patch and then suture this to the surrounding mucosa or the surrounding serosa, sorry. Now this is what we call it as the Graham's omental patching. So you did a primary repair of the perforation and then you put the patch on top, and this is what we call it as the Graham's omental patching, and that is what you do for your perforation or a hollow viscous perforation, right? So this is what we do for your hollow viscous perforation. Clear, guys? Clear? Any questions? Quick feedback. If you have any questions, clear. बेटा नीमोपेरिटोन ये जो फाइंडिंग है ना, दैट फ्री गैस अंडर डायफ्राम, दिस इज व्हाट वी कॉल इट एज नीमोपेरिटोनियम ओनली. नाउ दिस फाइंडिंग इज व्हाट वी कॉल इट एज नीमोपेरिटोनियम. This is what we call it as pneumoperitonium. That is, air under the diaphragm is what we call it as pneumoperitonium. Clear? Clear, guys? Quick feedback. Somebody is asked for cupola sign. Beta, cupola sign is a radiological sign जहाँ पे air ऊपर उठता है ना, in a supine position. When the air rises up, it comes in the central tendon of the diaphragm, right? तो cupola का मतलब होता है, when you look at the cupola's original meaning, no, it appears as if somebody is holding the hand like this. This is how the cupola would look like. ठीक है? I don't have the image of the cupola sign. If I can find one, I'll display it to you. But more or less, this is what the cupola sign is. Like the hand becomes like this. ठीक है? Clear? So this is how you will manage your perforation peritonitis. Okay. So two important complications of the peptic ulcer disease, and we have discussed both of them and its management. One is going to be bleeding, and in that bleeding you should remember the Forest classification and its implication. And in perforation peritonitis, the radiological signs as well as the management, that is going to be your Graham's omental patching. If you want to read two important TNMs for NEET, one is going to be a breast cancer, another one is going to be a colorectal cancer. Though must and must. Okay. Chalo, that's it for today from my side. Today, we'll resume back tomorrow again. We'll take up another topic. I mean, continuation of this, we'll talk about few more complications, and then we'll talk about complications of surgeries which are done for peptic ulcer disease, which are going to be specific, right? Until then, thank you so much. Take care. Have fun. See you guys tomorrow. बेटा ये गैस कैसे निकलती है, यहाँ पे डिओडिनम फटने की वजह से जो एयर आप खाने का आप हवा भी स्वॉलो करते हैं ना, वो हवा पेट में होती है ना, अब वही पेट में जो हवा है वो इस जगह से यहां से वो धीरे 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 करके लीक हो जाती है. दिस इज द एयर दैट इज गोइंग टू लीक. ठीक है, चलो, थैंक यू सो मच. हैव फन. टेक केयर. See you guys tomorrow. Bye bye.